We're going to get started. With the hour having reached 10 a.m., I'd like to call to order the CCH Managed Care Committee meeting. Roll call.
Director Harrington.
Present.
Director Staines is absent. Director Webster-Cross is absent. Serving as a substitute member, Director Kim. Present. And Chair Lowry.
Present.
You have a quorum, and I do see Director Staines has joined us remotely.
So with that, I'll now take a motion to allow remote participation.
So moved.
Second. All those in favor say aye.
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 All opposed? In the opinion of the chair, the ayes have it. Hello, Director Staines. Okay.
Good morning.
Good morning. Any additions to the agenda?
No additions to the agenda.
Public speakers?
We do not have any registrations nor any written testimony submitted.
Thank you. I'll now entertain a motion to accept the minutes of the Managed Care Committee meeting held on July 18, 2025.
So moved.
Thank you. Second.
Second.
Any discussion? Hearing none, seeing none. All those in favor say aye.
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 Opposed? In the opinion of the chair, the ayes have it. We will now hear a report from Health Plan Services presented by Aaron Galiner, Chief Administrative Officer of Health Plan Services. Aaron.
Thank you, Chair, and good morning, Directors.
Morning.
I'd like to start off today plan successes. Then we'll go through our usual metrics, through some strategy updates, including updates on the State of Illinois MCO RFP, and then do a deeper dive around our quality measures. So to start off, the first thing I'd like to acknowledge is our recent 4-star NC2A health plan rating. This is our second year in a row of receiving a 4-star rating. County Care was the only MCO to receive a 4-star or higher in the state of Illinois among Medicaid health plans, and that puts us in the top 22% of Medicaid health plans nationally.
And I think that's worthy of some applause. Great job. Go ahead, please.
The next slide shows some awards received from the National Association of Counties. We won 2 awards, one for our work with eliminating lead for drinking water for Illinois families. We provided a number of water filters to families that were in areas that had the potential for lead in their drinking water this past year, and also for our work for providing the health benefits for immigrant adults and immigrant seniors in Cook County. We've also been very active out in the community over the past quarter, so we have a couple slides here showing us at the Pride Parade, as well as at the Bud Billiken Parade. And then we've also hosted a County Care Children's Health Fair out at Providence Hospital, which had very good attendance, and we also hosted a community baby shower, which was also well attended, that was located near Calumet and Pullman neighborhoods. All right, for health plan metrics, we continue to see relatively stable membership, so we are at 398, just shy of 399,000 members. It's a slight decrease from the prior month, but overall very stable membership currently. On the next slide, you can see that in terms of market share, we've been still leading the market. We're at 34.7% overall market share. This data is published from the state and is through July of 2025. So this data now incorporates the loss of the HBIA membership that occurred in June. So about 16,000 of our members lost coverage at the end of June, which is now reflected in this data. So we were just around 35% market share prior to that change. That did have some impact, but I was somewhat pleased to see that the impact was relatively small in the overall market share numbers. The next slide shows some of the trends that you're seeing in Cook County Medicaid enrollment. So on the right-hand side, with the red line, you can see that Medicaid enrollment has continued to consistently decline. So we've seen that decrease for the past 2 years at this point in overall Medicaid enrollment. On the left-hand side, you can see County Care's membership has been quite a bit more stable. So you see periods where we've been pretty flat. We've had some periods of decline, and obviously the big impact there from June to July was that HBIA membership losing coverage that I mentioned before.
I have a question. What is the anticipated drop based upon some of the reductions in Medicaid funding from the federal government. And you can assume, or I assume, that this number is going to continue to go down, not going to go up anytime soon. And do we have some idea of where it might level off again, or where or when?
Yeah, so there's a couple different impacts that we're expecting. Most of the main impacts are likely to be in 2027, which is when most of the requirements go into effect. That includes the work requirement, as well as enhanced redetermination requirements particularly for the ACA adult population. So when you look at our membership, we have about 100,000 ACA adults in our plan, and we're expecting that population to be mainly impacted by those changing requirements. It's highly variable right now what the estimates look like of the impact of that. The federal government's expected to issue a lot of the detailed guidance by July of 2026, so that we'll really be able to dig into what that may look like. But I think that could range from anywhere from 10% to 25 to even as high as 50% impact on that AC adult population. So that would be anywhere from 10,000 to 50,000 members could be impacted within our health plan.
So I see the decline for the county care is like almost double the overall Medicaid decline in Cook County between June and July. What do you think explains that?
So that was almost entirely driven by that HBIA population that was eliminated from coverage. We had the vast majority of the HBIA population was in county care versus the other managed care organizations. So it was something like 16,000 out of the total 20,000 enrollees of the HBIA population were in county care. And so that's why you see the much higher impact that month.
Was it by design? We actually recruited people like...
Yes, so we worked very closely with the state with the rollout of coverage for that population, and so the state default assigned most of those members into county care when they first got coverage.
Thank you.
Because we've been noticing increases in charity care, and that's where these people may have wound up. So charity care is going up, and there's no compensation for that.
And I think related to that, we're seeing from the private insurance carriers huge increases in what's being quoted for coverage because of what's occurred with the federal government. What's the anticipated impact on charity care given this?
Yeah, that's a challenging question to answer. Certainly, nationally, there's going to be a significant increase in charity care, and coverage is going to be significantly impacted. I think in a variety of ways. A number of individuals potentially are going to lose the enhanced subsidies that are happening on the ACA exchange currently, which is going to cause them to make some decisions between either going uninsured, paying much more for their health care, in many cases almost double for their health insurance, or potentially moving to a much lower cost, lower coverage type of plan. And so all of those are going to have very significant impacts. For Cook County Health specifically, we have a large majority of our population is Medicaid and uninsured. We have a little less of the population that's on the ACA exchanges that are coming to us, but of those that are on the ACA exchanges, most of them are in that lower income side of the exchange, which is getting those enhanced subsidies, so it's going to have a disproportionate impact on that population.
Thank you.
So this slide shows how we're tracking versus our overall budget. We're continuing to see strong numbers in terms of our membership versus budget. Obviously, that HBI impact I mentioned from June to July brought us much closer to what was anticipated in this year's budget, but we're still expecting to finish this year well ahead of the overall membership budget that we planned. Next slide shows our operations metrics. We don't have any real call-outs here in the data. I think for our call center measures, And the claims and encounters data that we have to submit to the state, all of these are within our normal expectations. Of course, something we're watching closely. We do anticipate the potential for some additional call volume with a lot of the uncertainty that's out there in the market right now. And so we want to make sure that we're well-staffed and ready to support individuals that have questions or who need additional support navigating the current environment. All right, and with that, I'm going to hand it over to Chrissy Torino to cover a number of different policy updates.
Great, thanks so much. Good morning, directors. Chrissy Torino, Chief Operating Officer with County Care Health Plan. So I know we touched on this a little bit, but wanted to provide some more detail related to the federal changes that are slated to arrive in October and December of 2026. So we spoke a little bit about mandatory work requirements. Those are going to be for those that are in the Affordable Care Act adult population, as well as parents of children 14 and over, though there's going to be some exceptions that apply. And County Care has about 105,000 Affordable Care Act adults who are going to have to adhere to these new requirements. So it's really going to be something that we'll be working closely with our community outreach team to support members to get through these requirements. They'll be, we know that they'll have to show that they have worked at least 80 hours in a month, but we, as Aaron mentioned, we don't have all of the details about how individuals will have to show and demonstrate proof of this. There's also going to be a 6-month redetermination requirement for Affordable Care Act expansion adults, also impacting about 105,000 of our members, where instead of renewing their Medicaid coverage every 12 months, they'll have to renew it every 6 months. And we'll talk a little bit about some of the work that we do in the community in a moment, and how we'll need to broaden those efforts to really support our members. And then there's also some additional restrictions for immigrant populations where refugees, asylees, and some other immigrant types have previously qualified for Medicaid coverage. They are no longer going to qualify, and we have an estimated about 2,200 members that fall into that category. That's going to be going into effect a little bit sooner than those other two requirements in October.
I want to clarify something. When you talk about work requirements, I've heard that you could either work or provide some proof of volunteering.
That's correct.
That may not be compensated work, but you have to do something to demonstrate you're eligible.
That's correct. Yes, it can be work, volunteer, and again, all of the kind of guidance of exactly what kind of proof will be able to be provided for that will be forthcoming from HFS.
And how is work defined?
So work, I mean, as Director Harrington was alluding to, is going to have a pretty broad definition, is my understanding. So people will be able to demonstrate that they're volunteering, doing other community service, things like that. But some of those definitions are coming still, and so we'll need to work closely with our members to make sure that they're meeting the requirements. There are already some programs that do require that in the state of Illinois, like temporary assistance for needy families.
But we have not seen anything defined such as 30 hours a week or 40 hours a week or something like that.
Oh, there is a definition around the time for the amount of hours. So it's required that they work in the broad definition at least 80 hours per month.
Got it. Thank you.
And as we know, the majority of people who are on Medicaid are in fact working, and so it's going to be a lot of just administrative burden for them to be able to prove and maintain their coverage.
Thanks.
In terms of the volunteer hours, I mean, is it possible that they could do volunteer work with us?
Potentially. I think something that we'll have to be really thoughtful about, and something that in our discussions with some of our community-based partners, we just want to make sure that there isn't any potential thinking that we are requiring people to work to stay on county care, for example. But we are thinking about ways to partner with the community-based organizations that have volunteer opportunities and workforce development to make sure that those are available to our members.
So the fact that the majority of people actually are already working, is it just the burden of documenting? So are you planning on, providing some support for that kind of, burden?
Yeah, great question. So we are going to be expanding some of the work that we're doing currently in the community. Actually, would you be willing to go just ahead 2 slides? So currently we have an outreach team that's in the community providing events about 5 days per week. We provide support not only to county care members, but also to anyone who comes to our events. So this is just showing our events and attendance from September 2024 to August of 2025. We held 227 events during that time with about an attendance of 12,200 folks that came out, and we have about an average of just over 50 people that come. So we have a team that actually supports people and walks through the paperwork and requirements for redetermination, for SNAP, the Supplemental Nutrition Assistance Program, and as these requirements roll out, beginning in January of 2027, we will ensure that our teams are fully trained and able to support people through that process.
Thank you.
Thank you. All right. So going back just 1 slide, we just wanted to share a little bit about what the impact is going to be to the state and to county care. As Erin mentioned, you know, there's a broad range of potential coverage loss due to the requirements that come out, which are still forthcoming. Other states, however, have seen about a 20% loss, which could be around 21,000 members for us. And we, as I mentioned, for work requirements and for more frequent redetermination, we have about 105,000 members that are going to have to adhere to those requirements. Healthcare and Family Services has projections that between 270 and 500,000 members could lose coverage. And again, that range is broad given the forthcoming guidance. And then internal HFS projections also show that Illinois will likely face about a $26 billion reduction in federal funding, but that's going to be over the next decade. So any questions about any of those updates? If not, I'll move on to updates on our request for proposals. All right. So excited to share an update on our current in progress response to the Health Choice Illinois RFP. It came out on September 15th from the Illinois Department of Healthcare and Family Services. As a reminder, we are currently under a contract that started in 2018. That was extended through the end of 2026. So we must submit a proposal to continue to act as a managed care community network beyond 2026. So the new contract would go into operation January 1st, 2027. On the next slide. So the RFP was released in September. We are working away to get our RFP submission completed and are in really good shape for a strong submission on no later than November 13th. So we are planning to submit a couple days early to ensure there are no snafus with submission. And then on the next slide, so after the RFP is due in November, we anticipate a notice of award in February of 2026. The state is hoping to execute new Health Choice Illinois contracts for a July 1st effective date, as we'll be implementing all of the new changes to the new model contract. Open enrollment will start in fall of 2026, and then we will start under the new contract on January 1st, 2027. So once we submit, we'll be moving towards implementation of the new contract pending award.
So when do we get the opportunity to exercise the option to renew for up to 5.5 years?
So the state comes out with amendments following the initial contract term. So they extend the potential to renew that contract to the managed care organizations, part of Health Choice.
That be in 2027 or?
So So the contract goes from July 1st, 2027 through December 31st of 2030. So, likely in, sometime in 2030, they would come out with a new amendment at that time. Thank you.
Do we know, this is Heather online, do we know if HFS is going to make any changes to how they assign members who don't request a particular MCO, what their default algorithms will be?
They have the opportunity to change the auto-assignment algorithm at any time. It is part of the model contract that they have the ability to auto-assign and change that algorithm. That being said, County Care has traditionally had a high auto-assignment of about 50% in Cook County.
Yeah, and we expect that that's going to continue. That's really why I was asking that, because I feel like we've done well on that, and we expect that that will continue then. There's no reason to think otherwise.
I would say that at the beginning of the new contract, that will be a time where potentially Healthcare and Family Services would be looking at their auto-assignment algorithm, given that there's the potential for new entrants or changes to plans leaving Health Choice Illinois. So to your point, there could be the opportunity for them to look at it at that time and make some adjustments.
So the fact that you have a risk-based contract, does it mean that you're getting higher rates of reimbursement for the high-risk people?
Yeah. Aaron, do you want to take that one?
Yeah, so the way the contract works is they define a rate each year for individuals. They do it on what they call a rate cell basis, so it's typically an age and demographic breakdown. So, for example, by population, so ACA adults will get paid a certain rate for males age, 25 through 32, for example. So it's broken down kind of that level. Then beyond that, there's then a follow-up risk adjustment process that happens where they look at disease prevalence between managed care organizations, and if one managed care organization has a higher disease prevalence than another, they will shift funds to account for that in the revenue that you receive. And then on the auto assignment question, I think, as Christy mentioned, there's not a ton of detail that's out there around that. I think from a policy perspective, we continue to expect that's mainly going to be driven by quality. I think the way the state defines what quality measures they're looking at to drive that algorithm is something that's going to be probably an open question. And then I think to Christy's point, the other question will be when they move to the new contracts, will they look at historical performance of plans that are already in the market to drive auto assignment in that first year of the contract, or will they kind of baseline everyone to a set rate that first year and then make changes to the assignment algorithm based on that first year's data? So I do think there's a little bit of risk to us in the auto assignment process in that first year, but it's to be seen how they're going to approach that.
Thanks, that's really helpful. Let's hope they go based on quality.
Yes, we're very well positioned. If they continue to focus on quality and innovation as part of their justification for our high auto assignment, they've also traditionally auto assigned certain populations to County Care based on our longstanding relationship as a provider. Okay, I think with that, unless there are any other questions about the Health Choice Illinois RFP, I'll pass it over to Dr. Collins to cover quality.
Absolutely. Good morning, everyone. Yvonne Collins, Associate CMO. As we talk about quality, it's really exciting to bring you all some updates on our quality program. Just to level set for just some reminders, we're going to talk about our NCQA rating, which you saw are 4 stars, which is a combination of HEDIS, which is a healthcare effectiveness data and information set, which is really a standardized proportion of performance measures that more than 90% of all health plans are graded against. In combination with that, we'll also look at the consumer assessment in healthcare providers and systems, which is really an annual survey where our members get to grade us how well we did that prior year, and the combination of those things is what goes into our weighted score, that 1 through 5 rating. Next slide.
I have a question.
Yes.
What distinguishes prevention, because you have prevention and equity, so that's one bucket, but is there a difference? I mean,
Yeah, so there are specific categories of, so when we think about prevention, it is controlling blood pressure, hemoglobin A1C, medication management of asthma, those are some examples. Their equity bucket are most of the cancer screenings, breast cancer screening, cervical cancer screening, colon cancer screening.
That's because of...
That's just how the system breaks it down. We don't break it down.
But it's really based upon disproportionate incidence of those things occurring when you look at it on the basis of race?
Not necessarily, because we look at all of our measures based on demographics of age, sex, and race. And so the equity components are not looked at solely based on race. I think they denoted those because of the disproportionate health equities we see related to those diseases.
So what data do they use to establish that? That's what I'm trying to understand.
In terms of HFS and how so they probably use our state metrics related to how well the state is screening particular populations. So if you look at it, so these are rates that we're going to look at, our rates for 24. If you look at 22 and 23, they look at how well we screen particular populations and various measures. They then use those measures to create categories. And I would imagine, and I can definitely go back and look at it, but for those measures where populations, especially when you break those populations down based on race and ethnicity, did worse, those are measures they wanted us to focus on from an equity perspective. And I'll use air quotes there, because for all of these measures, we actually look at them from an equity perspective.
Yeah, I understand that. I guess partly why I'm talking about this is I know that the current federal administration is averse to anything that says equity.
Right.
And do you see these criteria changing and just having to focus on prevention with no focus on equity?
We haven't seen that thus far, at least what we've gotten in terms of the way we need to report as it stands now. They have not removed any of those connotations at the state level. We know when we look at NCQA, there have been a lot of iterations for change related to race and ethnicity for the NCQ Health Equity Accreditation. But solely for HFS and our HEDIS measures, we haven't seen that yet.
And so for NCQA, which is an association, an accrediting agency, what types of changes have you seen? Have they pushed back or have they pulled back?
Yep, not necessarily pushed back. They have eliminated standards. So we previously were starting to look at sexual orientation. With the new standards, that's completely removed. We were beginning to look at assessments of LGBTQ and how they get their care and measures around those were completely removed. They're really limited when we look at health equity. They're limited it to my goodness, not enough caffeine this morning. It's really to language is their big area. Disability is another big area, but those are the things that they have completely removed from our accreditation. Anything you want to add there? Yeah.
So you can't make if moving forward, we can't make an accurate appraisal of where we were to where we will be in the future. Some things have been eliminated, so it'll be a whole different.
Well, for NCQA, the health equity accreditation portion, we are just now going through that accreditation for the first time. Okay. So this will be our baseline. Okay. And some of those things, are we being recorded? Okay, I'll leave it there. Any other questions? Yeah. Next slide. So just the next slide really highlights how we look at that overall rating. So as a reminder, patient experience is CAHPS, our quality measures is HEDIS, and then the third component is our NCQ Health Plan Accreditation, which we will be also going through this fall. If you look at those three categories that Mr. Harrington was just talking about, patient experience is about 14% of our points. Prevention and equity, which are disease categories, are about 25%, and then our treatment measures about 61% of those total points. And that's how they come up with the grading system that we're going to talk about momentarily.
How many people, because you say only the top 22% of the Medicaid health plans have to achieve a 4-star rating, so some have more than 4?
I don't think for Medicaid, and keep me honest, Aaron and Chrissy, I don't think there are any Medicaid plans that have 4.5 or 5 stars. That's Medicaid is 4.
There are a handful that have 4.5 stars. There are no Medicaid health plans that have a 5-star rating.
Yeah.
So we're as high as everybody else.
Yeah.
Thank you.
We're going to get T-shirts that say 22. All right. Next slide. You saw this slide already, but we're going to put it in stars and lights. We're really excited for our 4 stars, but I'll keep going because you guys saw that slide already. The next slide really highlights and digs deep into some of our ratings. So the first portion of this, and you can see County Care and Cook County Health are highlighted in the yellow. This is sort of when we look at our 4 stars, that's that very top row. You can see how our competitors on both sides compare related to overall rating. You can see all of the other plans were at a solid 3.5. If we go to the next row that looks at patient experience, you can see we scored the highest with a 3.5 in that particular category. When we look at the third row, prevention and equity, again, no other plan hit the 3.5 mark. And then when we look at our treatment category, pretty much 3 across the board. So you can see where the differences were related to those areas in terms of how we did compared to our competitors.
Yeah, if this were a race and we appear to be ahead, I wouldn't slow down.
Right. We're not. We're going full speed ahead.
What is treatment category?
So those are how well we're doing with our behavioral health. So follow-up after hospitalization, how often we're using antipsychotic measurements in our children, things like that. And if you guys are interested, we can give you the breakdown of what falls in each of those categories for future. Other questions? The next slide digs a little bit deeper into member experience. This is where we're really, really excited. Again, you can see County Care highlighted in the yellow, our competitors on both sides. We can see for member experience, again, we got that 3.5, but I'm going to take you down to the second row from the bottom second row from the bottom, rated of the health plan. County Care was the only health plan, maybe I should say that again, only health plan that got 5.0. So you can see we had plans that had 1 and 2 and 3 and 4, but we were the only plan that hit 5.0 stars. So that means that our members are extremely satisfied with the care that they get within our health plan.
I'm just curious, like, patient experience category for Aetna is like 1.5. So I'm just curious how people make decisions about their, so do people actually move between different MCOs?
Absolutely. And Chrissy may want to take this. She does a lot of work around this. But I think we're really intentional about getting our member perspective. So just use, for instance, our marketing campaign. We do a series of focus groups. We do them in Spanish and English. We get different populations, different age groups, because we want to know what keeps you at County Care. And those are the things we want to hone in on. Opportunities, we get those opportunities also, and that's where we make changes. And I think that's really a lot of what separates us from the other plans. And we do see, we've had members tell us, because you cover, LASIK surgery, I'm moving from Aetna to County Care. Because, whatever it is, the service that we provide that they think is better than other health plans, they've moved for those distinct reasons, absolutely. And they have that opportunity to move between plans. So we're always looking at, are there opportunities for us to improve our services, our benefits, our rewards?
Yeah, the only thing I would add, so as Dr. Collins mentioned, there's a time every year where people can choose their health plan, and we have seen over time that increase. So we are now at the point where, even though there are 5 health plans, 1 out of every 3 people who chooses a health plan is choosing County Care. I think a lot of it is based on what Dr. Collins mentioned about really listening to our members and creating lots of forums where we get feedback. In addition to what was mentioned about focus groups, we do regular surveys where we get both qualitative and quantitative data back from members about what's working well or not. We look at social media posts, we have councils with enrollees, and we listen to our members about what it is that's, you know, going well, but also really what's not and what we need to do better. And then, you know, over the last couple of years, we've had a really kind of targeted focus on overall member experience. And, you know, due to that, we changed our transportation partner and have seen a lot of improved satisfaction there. Our directory and digital tools, all based on member feedback. So, and then we make sure we communicate that back, that we've listened and that we're making these changes based on what members are saying to us. So I think that's a lot of it. We're going to continue to focus on, and as we always have been, as a community-based plan on our members.
The one other thing I'll add is that our frontline staff also do a really good job of, when they're in the community, reminding members of what their rewards and benefits and services are within the health plan. Because every day it's amazing. Like you'll meet somebody, they'll be like, County Care does not cover, and we'll be like, sure, we cover that. And so just that reminder, so making sure our line staff are fully educated about all of that, so that when they're meeting members all day, every day, they can really highlight that.
Can you tell that we care a lot about member experience?
We do, yes, we do. We should have put some stars by that side. All right, next, any other questions? All right, next slide really looks at, we really wanted to just give you a time frame and trajectory of how the progress has been going. So if you look at the left graphic, you'll see from 21 to 25 how we have continued to rise related to our NCQA health plan ratings. And then the right just gives you a bar graph of each of those 3 sections that we talked about. And what I also want to reiterate here is that I think a lot of this work is because when we look at NCQA and when we look at our healthcare rating, it really is not just the quality team, it is the entire health plan. And I'm going to talk about it in another slide, but the health plan in totality really gets in behind moving our health plan ratings, which you can see in the progress that we've made here. Next slide. Again, I want to highlight, we looked at our measures where we were low performing in measurement year 23. I'm pleased to say that more than 90% of those low performing measures are no longer low performing measures. We moved the needle pretty significant on asthma medication ratio management, on testing for pharyngitis, on our follow-up after mental illness, especially 7-day, and our controlling blood pressure. We are really excited about that. We do realize there is some opportunity there, and we're looking at really that population of our children and adolescents and behavioral health, and ensuring that we get our teams out to remind providers on the importance of that testing. But overall, really pleased on improvement in those measures.
And there was a drop in patient experience in 2024. Do you know what occurred? It's back up to where it was in 2023.
Can you go back one, I think, on the previous slide?
2023 was at 3.5%, and then it dropped below that in 2024, and then went back up to 3.5.
Yeah, so the patient experience is all based on CAPS, our CAPS ratings, which is a survey that we send out one time per year, though, as I mentioned, we have ongoing surveying that we do with our members. I can't pinpoint like one specific item that would be the reason that it would have gone down, except that, you know, I think we have been very intentional, especially over the last year, around communicating the benefits and rewards and services that we have in place. So I think, you know, if anything, it might just be that we really kind of ramped up those efforts over the last year with our County Care Rewards You campaign, making sure that people know what's available to them. And then as such, we've seen, that people are utilizing those rewards, getting them, and for the most part, spending them on food. But, I think that would probably be what I would expect as to why that increased again.
Yeah, I would just add to that. I think 2024 was somewhat unique in the sense that that was the year that redetermination started again. So I think, whether maybe correctly attributed to county care, the plan, versus just people's experience with their health care coverage that year, I think that was a year that there was likely a lot of just general frustration with the wave of people going through redetermination, the process of that, losing coverage, gaining coverage maybe a few months later. So I think that was a particularly challenging year, both from people's actual experience, but then the perception of why that was occurring.
You can go 2 slides for me. So Director Harrington said it, the race continues. We are on our way, although that says 4.5 stars, we're on our way to 5 stars. But this is our 4.5 strategy that we're working on for 2026. Again, all departments on deck to look at continued improvement. We've identified specific work streams and work groups so that we can really hone in. So provider engagement in pharmacy. So looking at those quality measures that fall under pharmacy. What can our pharmacy team continue to do or do better? Where can we engage providers better? Our member and community outreach, continuing to get the responses and challenges and opportunities from our members, but are there other ways that we can get into the community? So we have a women's fair, we have a men's fair, we have a children's fair, we have a community baby shower. 26 is going to, well, actually 25, because we're going to have the first one in 25. We're beginning to do disease-based fairs where we're going to focus on hypertension. Not only are we going to teach you about controlling your blood pressure, we're going to do some nutrition counseling. We're going to do some tasting demos. We're going to do some mindfulness and exercise, really so that our members can begin to understand the full realm of how they control those diseases. We can't do any of this without data. So really looking at how we integrate our data, we know that's a huge opportunity for us. A lot of our teams do a lot of data manipulation manually, and we know that's not the best. So looking at how we bring in additional EHRs into our system, how we're getting additional data around all of our HEDIS measures. So our data and quality teams are looking at that. And then are there opportunities for us to hone in better on our benefits and programs? Is this an opportunity for us to look at new programs and new benefits? So this is a little bit of work that these work streams are going to be doing over the course of the next year as we do our march. Next slide looks at really how we're going to do that. So we have performance improvement work groups for each of those work streams that are talked about. We continue to look at our provider and CME partnerships. We have quality meetings, specific provider meetings, joint operating meetings where we're constantly allowing our providers to see in black and white their metrics and really having sometimes hard conversations about how we move the needle on those metrics. I talked a little bit about our data improvement. County Care, again, compared to other MCOs, has a vast suite of value-based contracts around value-based care and incentives. How do we continue to increase those? Because some of our data shows that some of our providers that are in those value-based contracts are doing better, and we want that across the health plan. Member engagement we've talked a lot about, but we're going to continue to hone in on our members' needs and how we can revamp, communicate, and continue to be comprehensive along those lines. So that's just a little bit about what we've done, what we're planning to do as we march to 5 stars, and I think that's the last slide. Happy to take any questions if there are other questions.
Any other questions or comments, directors?
What do you actually hold as events and fairs?
So we have held our men's fair, women's fair, and children's fair at Providence. We'll put it on the record, absolutely fantastic partners. Our community baby shower has moved based on the data. So we look at, we focus on prenatal and postnatal care, so we look at where are those zip codes where the most education is needed, and that's where we have our baby shower. So we had our first baby shower at Provident. We had our next one at Sinai Community Institute. We had the most recent one at the Shine Center in Chatham. So the data really dictates that. We're probably going to start to look at that as we look at the other fairs also, how we move them around our geographic area so that we can touch more members.
Thank you, that's really wonderful.
Yeah, thank you.
Aaron, did you have something?
I just wanted to take a minute to thank Chrissy and Dr. Collins for their leadership. I think you can see a lot of the impact they have and the way they set the culture with our team. So want to acknowledge their efforts, and then I also wanted to take a moment and introduce Dr. Tanksley, who is going to be is stepping into our Chief Medical Officer role, and Dr. Collins will still be with us. She's transitioning into our Associate Chief Medical Officer role, so she hopefully can have a little bit better balance between work and her I don't know if you call this retirement or post, kind of more balance there. So anyway, we're excited to have Dr. Tanksley join us, and just again want to thank Chrissy and Dr. Collins for their leadership.
So thanks for that great report. And let me say this, Dr. Collins, you may think in some ways you're getting out, but you're not getting out. And I say that knowing we're recorded. Dr. Tanksley, you're a friend of mine. I've known you, and we're even a stronger team adding you to that team. So very excited to hear all this. So hearing no other questions, we have any other comments, directors?
Nope.
All right, hearing none, seeing none. The committee's regular meeting schedule for 2026 has not yet been determined, but soon you'll get probably notice of the January date. That's what we're anticipating. And with that, and having no further business before this committee, I'll now take a motion to adjourn. So moved. Is there a second?
Second.
All right. All those in favor say aye. We're adjourned. Thank you. It's a great report. Thank you. Appreciate you.